Good evening, delegates and participants. Thank you for joining Shield Connect. And today we have speaker with us from Jamshedpur, Dr. Indu Chauhan. And ma'am is going to take a topic, ovulation induction in PCOS. So before I start the session, let me give a quick introduction of our page, Shield Connect. This is our page, shieldconnect.in, where you can find there are various sections are available. So the first section is the blogs section, where you can find all the latest blogs written by the eminent speakers and doctors. And then we also have a webinar section, upcoming webinars and past webinars. So you can find latest webinars that are going to be conducted on our page. If you click on see more, you just have to register through your email ID and you can see our webinar of today's session. And in this comment section, participants, please post your queries. So at the end of the session, we can have a Q&A session with our speaker for the day. Then we also have a special awareness pages like PCOS, menopause, GDM, COVID-19 immune booster, and thyroid awareness pages. So you can find all the different videos regarding each topics. Then we also have our leader section, where you can find all the speakers and doctors who are connected with Shield Connect. So you can also go through their profile in detail. And we also have a special day pages like hypertension, mothers, safe motherhood, and Women's Day. So this is our page, Shield Connect. And now let me give a quick introduction of our speaker, Dr. Indu Chauhan. Ma'am has done MBBS, MS in obstetric and gynecology. Ma'am is consultant gynecologist and endoscopic surgeon. And ma'am is director of Vardhan Maternity and Nursing Home in Jamshedpur, Jharkhand, and ma'am is life member of IMA and FOXY and specialist in IVF and endoscopic surgery. So I welcome ma'am, and we are glad to have you on our platform for today's session, ma'am. I hand over the session to you, ma'am.
Hello.
Yes, ma'am.
Good evening. Thank you very much for the nice introduction. Am I audible?
Yes, ma'am.
Yeah, okay. So good evening to everyone, to all the participants and all the delegates. So today I'm going to speak on ovulation induction in PCOS. So the scope of the talk will be introduction, diagnosis, management, ovulation induction, and then the conclusion. So we all know that PCOS is a very, very common cause of subfertility in all the females. And we say that the incidence of PCOS are increasing. Maybe it is the lifestyle is responsible for the increase of the PCOS cases, or we are able to diagnose these cases because of ready availability of ultrasonography as well as hormonal assessment, which is readily available nowadays in each and every nook and corner of the country. So when we talk about ovulation induction, why we need to induce ovulation? So what is an ovulation? An ovulation is the failure to release an oocyte from a mature Graafian follicle during a menstrual cycle in a post-menarchal and premenopausal woman. Usually it manifests as irregularity of menstrual periods, that is unpredictability of intervals, duration or bleeding. Most of these women have oligomenorrhea, which is defined as menstruation that occurs at intervals of 35 days to 6 months. Now, whenever we classify an ovulation or ovulation disorders, as per WHO, they are classified in 3 types: type 1, type 2, type 3. Now, what is type 1? Type 1 is a hypogonadotrophic hypogonadism that is caused by any lesion that is affecting the pituitary or hypothalamus and affecting gonadotrophic production. Now, type 2, where there is normogonadotrophic hypogonadism. The commonest cause of type 2 and ovulation is the polycystic ovarian syndrome or polycystic ovary disease. Type 3, that is hypergonadotrophic hypogonadism, usually an indication of ovarian failure, and hyperprolactinemia is one of the causes of type 3 and ovulation. Now, what happens in group 1? These women will have the following hormonal pattern: low estrogen, low FSH, low LH, and normal serum prolactin. Women with WHO class 1 ovulation will not respond to treatment with clomiphene citrate. So it is very important to know what is the cause of anovulation and in which group patient is fitting in. The treatment for this group consists of injection of GnRH or gonadotropin formulation, especially the formulations which contain LH. The women who fall group 2, the women who fall in this group have normal levels of gonadotropin and estrogen with anovulation. The majority of these patients, they have polycystic ovarian disease, and most of the ovulation inducing agents like clomiphene citrate, insulin sensitizing agents, and recombinant FSH, as urinary FSH and LH, these patients, they respond all these medicines very well. So we can induce ovulation with all these medications in this group of patients. Now group 3, in this, women in this group have high levels of gonadotropins with low estrogens. That means these patients, if we do their FSH LH levels, they have high circulating level of FSH and LH. The chance to conceive for women in this group is very, very low. If they are able to conceive, they have a very high risk of miscarriage because the quality of oocytes is also very poor. Response to hormonal treatment is again very poor. The only effective treatment for women in this group remains IVF with donated oocytes, because here the cause is mainly premature ovarian failure. Now, as far as PCOS is concerned, before going into the ovulation induction, let's just recapitulate about knowledge about the PCOS. This term was coined way back by Steen-Leventhal, and this is also known as Steen-Leventhal syndrome. This hyperandrogenic chronic ovulation is a benign disorder that commonly results in infertility. It is characterized by irregular ovulation and menses, obesity, insulin resistance, acne, and hirsutism. Most of the women on ultrasonography who has PCOS, they have got their ovaries, they are filled with multiple immature follicles or multiple with these follicles are arranged in a peripheral manner with a thick stroma of the ovaries. So ultrasonography is a very, very diagnostic, it has got a typical diagnostic feature of PCOS. Now, what are the symptoms of PCOS? They have got irregular or absent periods. These patients, they can have oligomenorrhea or amenorrhea altogether, like periods they are having periods which comes in 2 months, 3 months, 4 months, and sometimes they don't menstruate even for 6 to 8 months. Lack of ovulation. Most of these patients are overweight. They have got excessive hair growth, male-like hair distribution, insulin resistance, acne, acanthosis nigrans, the darkening of skin at the nape of the neck and under the arms and breasts. Now, to diagnose the PCOS, there are certain guidelines which we have to follow. The National Institute of Health criteria, the 2 criteria should be met before diagnosing any patient as PCOS, that is hyperandrogenism and menstrual irregularity. Androgen excess PCOS Society criteria, hyperandrogenism, menstrual irregularity, or polycystic ovaries on ultrasound. Out of these 3, at least 2 criteria should be met. Rotterdam criteria, which is most commonly followed criteria. Out of these 3, at least 2 should be present to label a patient as a patient of PCOS. Hyperandrogenism, menstrual irregularity, polycystic ovaries on ultrasonography. So out of these 3, if 2 are present, the lady is labeled as a case of PCOS. Now, when we diagnose a patient of an ovulation, the documentation of ovulation is very, very important. So how to document ovulation will come later. The most important tool to diagnose ovulation is the ultrasonography. Ovaries which are depleted of egg tends to be smaller. Now, when we track the follicle, we see how follicle is growing, and the follicle should rupture when the mean diameter reaches 18 to 25 millimeter and subsequently change in size, shape, or sonographic density. The changes in ultrasound image of a follicle, that rupture is disappearance or sudden decrease in size, increased echogenicity, irregularity of follicular wall, appearance of free fluid in the cul-de-sac or pouch of Douglas. So disappearance or sudden decrease in follicle size has been found to be the most frequent sign of ovulation. Sensitivity and specificity of ultrasonography to document ovulation is 84 and 89% respectively, and accuracy is about 85%. So the follicular tracking by ultrasound is the most confirmed diagnosis of ovulation or anovulation. There are other tests also, but these are indirect tests. So we follow mostly the ultrasonographic evidence of ovulation or anovulation. Now, management. When we diagnose oligoovulation or anovulation unrelated to ovarian failure, it can be treated successfully with ovulation induction agents. These women achieve fecundability equivalent to that of normal couples. 15 to 25% probability of achieving a pregnancy in one menstrual cycle, which is ovulatory. Now, method of ovulation induction selected should be based upon what is the underlying cause of anovulation. I had already discussed which group the patient falls in. What is the efficacy of the agents which we are using, the cost of the agents, what is the risk of these agents using in that particular patients, and potential complication associated with each method. So the management options include weight modulation. Most of the PCOS patients, they are on the higher side of their weight. Very, very important thing is that they should be optimize their weight. It is known fact that if a PCOS patient whose BMI is high, who is overweight, the 10% reduction of weight, just by 10% reducing the weight, many a times these PCOS and ovulatory patients start ovulating on their own. Clomiphene citrate or other SERMs are the first line of management. We can use other adjuvants like metformin or other insulin sensitizing agents, aromatase inhibitors, gonadotropin. If all these therapies fail, LOD, laparoscopic ovarian drilling, can be used as one of the tools to induce ovulation. If the patient has got hyperprolactinemia, bromocriptine can be used, or other dopamine agonist can be used as an ovulating agent. Assisted reproductive technology requires ovulation induction that I'll be discussing later. Now, flow chart of diagnosis and treatment of anovulation. History and examination. Day 2 FSH and prolactin is done. If there's increase in prolactin levels, pituitary imaging and thyroid test TSH should be done. If there is hyperprolactinemia, dopamine agonist should be given. Rarely these patients, they require surgery. Most of these patients, they respond very well by dopamine agonist, bromocriptine or gabagoline. If FSH is high, if the cause of anovulation is high FSH, that means the ovaries are refractory. Karyotype should be done and autoantibodies should be checked. If there's hypergonadotrophic hypogonadism, most of these patients, they can be given pregnancy by donor eggs. If FSH is low, again the body weight should be seen, pituitary imaging should be done. If there's hypogonadotrophic hypogonadism, the gonadotropin therapy is the mainstay in the treatment of these anovulatory patients. Now let's come to the WHO type 2 anovulation. That is, there we have all the gonadotropins within normal limit. That's normal FSH, LH is normal, thyroid is normal, prolactin is normal. Pelvic scan is done. And if the patient is a case of PCOS, the mainstay of the treatment is weight reduction, anti-estrogen, letrozole, insulin sensitizing agents, gonadotropin, and last resort is the ovarian drilling. Nowadays, we do ovarian drilling as a last resort. Now, what is the aim of ovulation induction? The aim of ovulation induction is the induction of follicular growth so that we can do timed intrauterine insemination or ovulation, ovum retrieval, egg retrieval. So timed intrauterine insemination and egg retrieval is to be done. So pharmacological agents initiate or augment the modulate the hormonal and gametogenic response of the ovary. They overcome natural follicular selection process to increase the number and quality of oocytes which are available for fertilization. Now, before going for the ovulation induction, there is a term which is known as ovarian reserve. So we should analyze what is the ovarian reserve in that particular lady before starting any ovarian stimulation, so that it helps in selection of the correct stimulation protocol and define the proper goal of ovarian stimulation. So the ovarian reserve markers, if they are done and if they are evaluated, they predict the response. They tailor the correct stimulation regime for adequate response so as to prevent complication and to improve pregnancy rates and pregnancy outcomes. Now, how to judge ovarian reserve, how to diagnose what is the ovarian reserve in a patient? The two very, very important modalities are anti-Mullerian hormone testing. It correlates with the number of antral follicles in the ovaries. Levels do not vary with the menstrual cycle and can be measured independently of the day of menstrual cycle and decrease with age. So we know that AMH decrease with the age and it is directly correlates with the number of antral follicles present in the ovaries. Healthy women below 38 years of old with normal follicular status at day 3 of menstrual cycle have AMH levels of 2 to 6.8 nanogram per ml. If it is less than 2, it indicates poor ovarian reserve, and in cases of PCOS, high levels of AMH is found, which again compromises female fertility. So the levels above 6 or 7 are again not very good, and levels below 2 are again indicates that the patient will have difficulty in ovulation induction. Along with anti-Mullerian hormone, a very good indicator of ovarian reserve is antral follicle count. It is counted by vaginal ultrasonography. Nowadays, we have got wonderful machines available, and we can count the antral follicles on any day of the cycle, but it is best to count the antral follicles immediately after menstruation or day 3, day 4 of the start of menstruation. So along with female age, the best tool which currently we have for estimating ovarian reserve is AMH along with antral follicle count. And it directs us how to induce a female for ovulation induction. So now we use two terms, witness ovulation induction and controlled ovarian stimulation. So now what are these terms? How to define these terms? Ovulation induction is pursued in patients who are not ovulating. So here the goal is monofolliculogenesis, whereas controlled ovarian stimulations for women who are already having ovulatory cycle but are still experiencing infertility. Here we want multifolliculogenesis. So we want to induce ovulation so that we get more number of follicles, more number of oocytes, especially in cases of assisted reproductive technology and IVF. Both treatment incorporates many of the same medications. Now, commonly used agents for ovulation induction are Clomiphene citrate, Aromatase inhibitor, tamoxifen and letrozole, Gonadotropin, HMG, urinary FSH, recombinant FSH, GnRH agonist, GnRH antagonists, and various adjuvants like metformin and N-acetylcysteine. Now, when we talk about ovulation induction, the choice for ovulation induction is dictated by hypothalamic pituitary ovarian function. When there are adequate hypothalamic function, the oral regimen of clomiphene citrate can be used. If hypothalamic or pituitary dysfunction is detected, then oral regimens are not successful. Here, injectable gonadotropins are administered. FSH administered alone or in combination with NH. There are step-up, step-down protocol which are mainly used in IVF, which I'll be discussing later. So now to start with clomiphene citrate. The typical initial dosing regime for clomiphene citrate is 50 milligram once daily for 5 days, starting on, not day 5, but day 2 of menstrual cycle. Some clinicians, they start on day 5, but I prefer to start on day 2 or day 3 of the cycles. Ovulation typically occurs 5 to 12 days after the 5th dose is taken. If ovulation is documented but pregnancy does not occur, the same dose of clomiphene citrate is used in future cycles. If ovulation does not occur, then the dose is increased by 50 milligram with each subsequent cycle. Though the product labeling does not recommend doses above 100 milligram per day, but clomiphene citrate doses as high as 250 milligram have been described in the literature, and very commonly 150 milligram per day is used successfully in various papers, literature, and even in the commonly we see the dosage of 150 milligram to be used in patients, and this can induce ovulation. Now, what is the mechanism of action of clomiphene citrate? It exerts its major effects on hypothalamus, pituitary, ovary, and uterus. Most evidence suggests that the primary site of clomiphene action is the hypothalamus, where it binds to the estrogen receptors. It blocks the negative feedback effect of circulating endogenous estrogen. Now, the elevated plasma concentration of FSH and LH hormones are there, which leads to, when clomiphene citrate is administered to normally cycling women, LH pulse frequency increase in GnRH pulse frequency. Now, this leads to the folliculogenesis. The administration of clomiphene citrate produces an increase in LH pulse amplitude, increase in the daily plasma concentration of LH and FSH, ultimately leading to the follicular growth and ovulation. Now, how to use? To start on the day 2 of cycle for 5 days. Ultrasound to be done on day 9, 10th, 11th, 12th, 13th as per your this thing requirement. But most of the time we see ovulation somewhere around 5 to 12 days after the last dose of clomiphene citrate. Now, how to increase the dose? As I had already discussed, 50 milligram for 5 days. If there's ovulation, same dose to be continued for 3 to 6 cycles. If there's no ovulation, increment should be done by 50 milligram every cycle. And even after 150 milligram, if there's no ovulation, consider alternative or combination treatment regimen for ovulation induction. Now, points to consider: PCOS is responsible for 75% of anovulatory infertility. 25% of these PCOS are CC resistant. 50% who ovulate have thin endometrium, because clomiphene citrate has got detrimental effect on the endometrium, as well as it causes the thickening of cervical mucus. Now, ultrasound monitoring is very, very important for the dose adjustment. If necessary, if there's an ovulation, the doses can be adjusted in the subsequent cycles. The ultrasound monitoring also allows us the endometrial evaluation. In IUI, endometrial appearance thickness is more important than follicle size for HCG administration. Assessment for the risk of OHSS is also done by ultrasound monitoring. So once ovulation induction is done, ultrasound monitoring is very, very important, even when we are doing the ovulation induction by clomiphene citrate. Now, the next group of drug is aromatase inhibitor, letrozole or N-acetylcysteine. This causes decreased estradiol production by inhibiting aromatase enzyme system and inhibits conversion of androgen to estrogen. So what it causes, the aromatase inhibitors, they inhibits the conversion of androgen to estrogen. We know that androgen is the precursor of estrogen. So once there is less estrogen in the circulating system, this decreases the negative feedback, which in turn leads to the increased production of follicular stimulating hormone, and which leads to the ovarian follicular stimulation and ovulation. The recommended administration schedule is similar to the clomiphene. once daily for 5 days, starting either from day 2 or day 3 of the cycle. Letrozole 2.5 milligram or 5 milligram, and estradiol 1 milligram. Letrozole is more commonly used drug as compared to anastrozole. There is a reduced incidence of multiple gestation pregnancy compared to clomiphene citrate because letrozole is it causes monofolliculogenesis. The pregnancy rates with letrozole appears to be similar to clomiphene citrate in spite of producing single follicle. Now, what are the adverse effects? Aromatase inhibitor does not affect cervical mucus or endometrial development. But this finding has not translated into improved pregnancy rates as compared to clomiphene citrate. Now, there was an initial concern of teratogenic potential of aromatase inhibition during fetal development, and that prompted a warning against use in premenopausal women for ovulation induction. But of late, this doubt has been cleared by various papers presented and the prolonged use of letrozole. Now we are using it for a very long time, that there is no potential teratogenic effect of letrozole if the baby is conceived with the help of letrozole. Now, metformin combined with clomiphene citrate may increase ovulation rates and pregnancy rates, but does not significantly improve the live birth rate over that of clomiphene citrate alone. Metformin may increase the live birth rate among women undergoing ovulation induction with gonadotropin, and it should not be used as first-line therapy for anovulation. So metformin is a very good adjuvant if used in PCOS patients, especially obese patients and especially the patients who have got very high insulin resistance. If their glycosylated hemoglobin is high, HbA1c level is more than 5.5 or sometimes 6, this metformin helps in inducing ovulation in these patients, and these patients, they have better chance of getting pregnant as compared to the only clomiphene or only gonadotropins. So when we talk about ART, again, the most stimulation protocols are based on the following parameters: age, FSH, AMH, and AFC. Age of the patient, BMI of the patient, which is very, very important, day 3 follicular stimulating hormone, AMH of the patient, and AFC of the patient. So when we give ovarian stimulation or control ovarian stimulation in ART, the criteria to decide the dosage of the gonadotropins or CC or letrozole, whatever we are deciding to give, is age, FSH, AMH, AFC, the combination of all these four with BMI to decide the dose. The ovulation induction is initiated on day 2 or day 3 of the cycle. The follicular size, the basal follicular size should be less than 10 millimeter, or there should be no ovarian cyst in the ovary when we are doing the basal ultrasound. Endometrial thickness should be less than 6 millimeter. Now the protocol the choice which is based on AMH and AFC, it can be antagonist protocol, agonist protocol, long agonist protocol, flare agonist protocol, ultra short protocol, ultra short agonist protocol, CC plus gonadotropin protocol. So the protocol has to be tailor-made. Now, what are these various protocols? I'll be discussing very soon. So the ovarian response depends on the presence of other infertility factors like endometriosis and various other factors, genetics, FSH and LH receptors, polymorphism, past performance of control ovarian stimulation, risk tolerance, FSH sensitive follicle cohort type of stimulation regime used, type of GnRH analog used, dose of gonadotropins. All are the factors which the ovarian response depends on all these factors. Now the choosing of GnRH analogs, non-PCOS, PCOS patients. In non-PCOS patients, We can use GnRH agonist, long or short, GnRH antagonist, and in PCOS patients, the preferable is GnRH antagonist protocol. This is minimal stimulation, antagonist protocol, agonist, long protocol. Now, what happens in GnRH antagonist protocol? The ovulation induction is started on the day 2 of the cycle. In fixed and flexible start multiple dose antagonist protocol. In fixed, the day 5, the antagonist is started. Whereas in flexible type, flexible start antagonist protocol, when the lead follicle is 14 millimeter or more than 14 millimeter, the antagonist is started. When the lead follicle reaches, most of the lead follicles, they reach 17 to 18 millimeter, trigger is given, and the egg retrieval is done after 35 to 36 hours of trigger. GnRH agonist protocol, the standard treatment protocol is long agonist protocol or short protocol. Long agonist protocol is very favorable in normal responders and results in an uniform cohort, whereas short protocol is used in poor responders and can cause premature rise in progesterone. Ultra short protocol again is used in poor responders. Microdose protocol, this is again used in poor responders. Now, what is the advantage of long GnRH agonist protocol? How long GnRH agonist protocol is used? We start the GnRH agonist triptorelin 0.1 milligram, the day 21 of the previous cycle. And once it starts, gonadotropins are added, and GnRH agonist is continued till the day of trigger. So it is stopped on the day of trigger. What is the advantage of long GnRH agonist protocol? It produces uniform cohort and more oocytes are produced, more M2 oocytes are retrieved. Increased pregnancy rate suitable for normal responders. Disadvantage of long GnRH agonist protocol is increased duration of controlled ovarian stimulation, which leads to increased cost, increased stress, financial as well as emotional, increased complication of OHSS, because in long agonist protocol, we have to trigger by human chorionic gonadotropins. Whereas in antagonist protocol, we can give agonist trigger, which prevents or decreases the risk of OHSS. Now, advantage of short GnRH agonist protocol, it utilizes the initial temporary flare effect for follicular recruitment followed by pituitary desensitization. More suitable for older patients and poor responders, reduces the dose of injections and duration of controlled ovarian stimulation. Disadvantage short GnRH agonist protocol, there is a reduction in the pregnancy rates as compared to long protocol. And secondly, there is sometimes a premature LH surge in short GnRH agonist protocol. Secondly, the cohort is many times it is not a uniform cohort. Now, what is the advantage of GnRH antagonist protocol? It is very, very patient friendly, reduced injections and shorter duration of stimulation. Minimal side effects, reduced risk of complication, because most of the antagonist protocols, the trigger is either done by agonist trigger or sometimes dual trigger if we don't foresee OHSS. Disadvantage of GnRH antagonist, again, uniform cohort of follicles may not develop. That is the biggest disadvantage of GnRH antagonist. Sometimes increase in dose of gonadotropins may be required once antagonist is initiated. So I was discussing what are the ovulation induction protocols. We can add along with gonadotropins even the oral ovulogens. Nowadays, in minimal stimulation protocols, we are using Clomiphene citrate or letrozole for first 5 days. Then from 7th day FSH, HMG in low dose can be added. The dose can be increased accordingly. And when the lead follicle reaches 18 millimeter, HCG trigger can be given, and IUI can be done, and progesterone and vaginal or oral or vaginal progesterone can be given for luteal phase support. So CC helps in recruitment of the follicles, whereas gonadotropin sustains the growth of recruited follicle. And here in these cases, when we want only one or two follicles to be grown, oral ovulogens with gonadotropin, low dose gonadotropin, it is a very good combination, especially for IUI and sometimes even for timed intercourse. The success of pregnancy is very good with this regimen. Now, when we use gonadotropins, it can be conventional step-up protocol, where to start with, we start the FSH in a low dose. After 5 days, depending upon the ultrasonographic picture, we can increase the dose of gonadotropins. After 5 days, again, if it is not satisfactory, we can further increase the dose. This is the conventional step-up protocol of gonadotropins. Step-down protocol, where the starting dose is high, and after 5 days, we start decreasing the dose depending upon the response to the gonadotropins. Low dose protocol, where the starting dose is low, and again we increase the dose after 5 days or 7 days by 100%. That means if we start by 37.5 or 75, after 7 days, if the favorable result is not there, the dose is doubled. That means 150 or 75 depending upon the starting dose. After 7 days, again, if the result is not favorable, further dose is increased by 50%. If result is favorable, HCG trigger is given when the lead follicle is more than 16 millimeter, and IUI is done accordingly. Step down protocol, again, the starting dose is high, and then accordingly the dose is reduced. In step down protocol, the risk of multi-folliculogenesis and OHSS is reduced. FSH threshold dose decreased by 50% when lead follicle is 14 millimeters. So this is a fact which we know about our physiology, that FSH threshold dose decreased by 50% when lead follicle reaches 14 millimeters. So this basis is taken to reduce the dose in step-down protocol. Now, there is one more adjuvant which I want to discuss, that is emerging role of N-acetylcysteine as a novel adjuvant to clomiphene citrate for ovulation induction. A promising agent is N-acetylcysteine, a safe and well-tolerated mucolytic drug. Proven activity of insulin secretion in pancreatic cells, acting as an insulin sensitizer. Anti-apoptotic activity, protective action against focal ischemia at level of ovary, apoptosis responsible for follicular atresia. N-acetylcysteine treatment improves insulin sensitivity, thyroid levels, and lipid profile of women with PCOS. It is proved and very effective in inducing or augmenting ovulation in polycystic ovary patient. It improves lipid profile of the PCOS patients, and the addition of N-acetylcysteine many a time induces ovulation in CC-resistant PCOS patients through inhibiting oxidative stress and improvement of peripheral insulin sensitization. Various papers have been published which concludes that NAC may be a novel adjuvant to clomiphene citrate, more effective than clomiphene citrate alone in inducing and augmenting ovulation. It could be used as an alternative to other insulin sensitizing agents like metformin. Many patients are not able to tolerate metformin. They have severe side effects with metformin in the form of nausea, vomiting, anorexia. So these patients can be given N-acetylcysteine as an adjuvant with clomiphene citrate for induction of ovulation. And the paper suggests, this is a paper published and it suggests that there is no statistical significant difference regarding clinical pregnancy rate when CC plus NSC is compared with letrozole group. So to conclude, addition of N-acetylcysteine to CC in ovulation induction leads to comparable pregnancy rates as letrozole, especially in CC-resistant PCOS cases. So to summarize, we know that anovulation is a leading cause of subfertility. But before inducing ovulation, we must know what is the cause of anovulation, in which group this patient fits, whether she fits in the group where there is hypo, when there is, so in that case, these patients will not have any benefit by oral ovulogens, the form of CC or letrozole, but these patients have to be treated by gonadotropins. If the patient fits in the WHO group 3, where she has got premature ovarian failure, again, that she has got very difficulty in ovulating, and many times the ovum donation, egg donation is the only answer. And if the prolactin levels are high, dopamine agonist treatment is the treatment of choice in these patients. If the patient is anovulatory because of PCOS, the proper diagnosis has to be made, and after making a proper diagnosis, the tailor-made management for each and every patient is the answer. All patients cannot be treated by one regimen, one way. Secondly, it's very important for what we are treating the patient, in the sense whether we are just giving her ovulation induction for timed intercourse, if we are giving ovulation induction for IUI, or we are giving ovulation induction, that is controlled ovarian hyperstimulation for IVF. So for each and every patient, the treatment has to be tailored. Not all, we can treat each and every patient by one regimen. Thank you very much. I hope I'm clear in my this thing, that how we should do ovulation induction in PCOS.
Thank you so much, ma'am, for giving the detailed information regarding the stimulation protocols in PCOS. So now let me check if we have any queries from the delegates. So, ma'am, there is one question. When is egg collection done during short GnRH protocol? Can I?
Egg collection is done after the 34 to 35 hours of the trigger. Whenever we give trigger, after giving trigger, 34 to 35 hours after the trigger, egg collection is done.
Then, ma'am, the second question is, according to you, ma'am, which IVF protocol is best for PCOS patient?
I prefer the step-up protocol for most of the PCOS patients to prevent OHSS. In PCOS patients, first thing is that you have to decide the dose very, very meticulously, depending upon the weight of the patient. And to start with, we should start with the minimum dose. And when very important thing is again the AMH of the patient. If AMH is too high, in the range of 8, 9, 10, these ovaries are resistant. In these ovaries, we have to start with higher dosage. But if the AMH is not very high, all other PCOS signs and symptoms are there. Ovaries, they have multiple immature follicles. Patients has got hyperandrogenism features in ovulatory, but AMH is not very high. Here, I prefer to start with minimum dose of FSH, and then increase the dose accordingly. After 5 days of FSH, do ultrasound. If you still feel that there is the recruitment is not proper, you can increase the dose. That is the ideal in PCOS patients to prevent OHSS. And secondly, in PCOS patients, nowadays we do totally we use antagonist protocol and all freeze. All freeze is there. We try not to do fresh transfers. All freeze policy, antagonist protocol, trigger by agonist. So we have to have OHSS free clinic.
Yes. So, and thank you for giving this answer. And the last question is N-acetylcysteine better than metformin in PCOS patient?
No, it's not. I will not say it's better. Both can be used. Both. I have used personally. I have used both the molecules.
Mhm.
Few patients they respond very well with an N-acetylcysteine, while few patients they don't respond with N-acetylcysteine. You have to gaze with each and every patient that what is better for her, especially in my
Mhm.
practice. I do HbA1c. If it is on the higher side, I prefer to use metformin. If it is on the lower or normal side, I prefer to use N-acetylcysteine. Again, the patients who have got high BMI, I prefer to use metformin, whereas in normal patients like normal weight or sometimes lean PCOS, NAC is better.
Thank you for giving all the answers to the questions. And we are glad to have you on our platform. And we would like to have more sessions with you on our Shield Connect platform, ma'am. Thank you for giving your valuable time with us today.
Thank you, thank you, thank
Thank
you.
you, ma'am. And thank you, delegates, for joining today's session. Bye, everyone.